Good morning, everyone. Excited to present today. So this is something that I feel kind of passionate about, and we will start with this little story here. So this is Dylan. He's my son. After 7 years of infertility and a million injections, more than I care to remember, this little bundle of joy was on his way. Unfortunately, at his 20-week ultrasound, we found out that he had bilateral club feet. So I was a NICU nurse at the time, and while this was not a bad diagnosis in comparison to a lot of the things I had seen, this definitely changed the way we were going to move forward with his care when he was born. And so it was a big event for us. It changed, he wouldn't be able to have baths with his casts on. What would he be able to wear? And then the main thing I worried about was would he be able to walk and enjoy life without pain? So kind of a big deal for us. We spent the next 20 weeks researching. We talked to providers. I found, the internet groups, people who had experienced this, and just did a ton of research so that my expectations and his needs were both met when he was born. Luckily, we had him, and it was a great experience. He did fantastic, and now he's a happy, healthy 6-year-old boy running around doing wild things like any other would. So that kind of leads me to our discussion today. What ways can we help improve outcomes for patients by doing some pre-procedural or education? So our case study here today is a 55-year-old male. He is Arabic speaking. His son is there translating. Unfortunately, we don't have a translator with him at the visit. He has no known drug allergies, taking gabapentin and tizanidine. When he comes in, he's endorsing some left leg, low back, lateral posterior pain, stops at his knee, and then he's got a positive foot and finger tenderness on that left side as well. So what questions or what things would you want to know about him?
How to start?
Yeah.
How long it's been going to see how long it's been going on? Kind of what's the history there?
So it's been about 6 months now. He was in an accident at work where he kind of fell on that left side there. So that was the injury itself. Yeah.
How long is the gap in that on board?
About 3 months.
So the CP gave that to him? Or?
Yeah, I think so.
Okay.
And he's done some other conservative care, so he's definitely done chiropractic and physical therapy without much relief so far. Yeah.
SI joint injection?
Nothing yet.
What about the SI joint exam?
Positive provocative SI joint exam. So we pull up his MRI here, and this is the L4-5 level. Do you guys see anything specific you're concerned about? Well, you're all correct. There's not much there. So he did have a little bit of facet hypertrophy going on, and there was some edema. This slicing doesn't show it great, but he was fixated on that in his visit. And I was more thinking, you've had an injury here, one of the main causes for an SI joint issue. Let's go do a diagnostic injection. So his son is translating all of this through our visit. Send him out to go do some specific physical therapy correlated with that SI joint and do a diagnostic injection. He comes back to clinic and he says, it didn't work. It worked for 5 minutes or an hour or two and was great, but then it didn't work. And so there was a lack of expectation for him. He expected it to be this long-going, long-lasting thing where a diagnostic injection is truly just a few hours of relief, and we see how it's working during that time of that lidocaine injection. So definitely you can see how where there was a language barrier and also his expectation, he felt like this was not working. And so I said, well, did you go do the physical therapy? And he was like, well, that wasn't the issue because it didn't work, right? So I think this really, to me, brought home an idea of his expectation was this. And so in his eyes, this treatment failed. And how important it is for us to be educating our patients on those kinds of things. So how are we able to set and meet expectations? Yeah.
I don't want you to back up a slide, but one of the problems you had was the language barrier on that.
Oh, yes.
Despite how well you communicated, you still have another, you're playing the telephone game that we played here a couple weeks ago, right?
Mm-hmm.
You're still just having somebody say like, oh, they said get an injection, Dad. Like, no, what I meant was it's a diagnostic injection, but you don't speak Arabic, so you had no idea that the translation didn't happen.
Exactly.
So for me, when we communicate with our patients, I want them to, I'll ask several times, like, do you have any more questions? Do you understand what this piece, right? And then this is what I hope to accomplish. Like, do you have any questions about that?
Yeah.
Sometimes they won't ask questions, but if they do, then at least you can set some more clarifying.
I love that. Yeah.
I think it's interesting how, although there's a language barrier, he very much understood the fact that he had an L4-5 arthropathy, that's that arthritis,
Uh-huh.
and somehow got that really well, but didn't understand your take on things. And I guess as far as communications and expectations of an SI injection, I don't know if there's any other injectors in the room or that can weigh in on this, but typically SI joint is injected with a corticosteroid as well. But there's a couple of different ways to inject the SI joint, but usually the pain generator is ligamentous.
Mm-hmm.
It's not the joint itself. However, if you're using fluoroscopy, you're going to do a lower pole SI joint injection, which sometimes isn't actually very beneficial. But if you inject the capsule and or the ligament, you have a better outcome. And there's several studies that show that. It's just that for some reason we don't inject capsules, we inject joints.
Yeah.
So my that's not an argument. I'm kind of hedging towards this guy. Like maybe he's right. Maybe
Yeah.
his expectations should have been higher, and I'm not saying that that's directed or not. Like he's just like maybe the pain generator wasn't actually hit as well as it could have been.
True. Yeah. No, I agree. Yeah.
One of the biggest things, kind of going back, that I would want to know is what are the aggravating factors and what are the alleviating factors, because if we can't take those away, we can inject this diagnostically to figure out, oh, it's an SI joint dysfunction, but if he's constantly irritating that SI joint, not loading it properly, then it's just going to come back.
True.
So having that education early on, I have to know what are those aggravating factors, and let's take those away, or let's adapt those or modify those, so that way we can actually take away the irritant rather than just mask it with some sort of injection.
Yeah, that's awesome. Yeah.
I always talk about with patients like setting realistic expectations, especially like after a neurosurgery and orthopedic surgery. Like, one of the things I'll ask them is what do you think the pain should be following surgery? And usually what they think and what is realistic is completely different. So we have a conversation about that. Well, you're gonna have some flare-up. You're gonna have some swelling and some inflammation. Oh, I didn't realize I thought it was just gonna be fixed. Well, it's not a fix right away. Let's talk in 6 months, So I think that making sure that your patients are understanding what is normal, realistic expectations following any procedure, any injection, any surgery, so that, and we can do that prior, and then they understand afterwards, like, oh yeah, Lindsey said that this was gonna happen. I remember this is gonna happen for this amount of time. Okay, yeah, I can work through this.
Yes, I think that's really key with our patients. If they're expecting something, we've gone through it. Like, hey, we're going to do this next surgery on you. You may have difficulty swallowing. Them knowing that when it occurs, it's not frightening to them. They're not like, I'm the odd liar out here, and what went wrong? They're thinking, oh, this is normal, and I can work through this. So, setting those expectations is very important.
Well, I was also going to say, I feel like it's so surprising how beneficial it is to overkill in education. Like I feel like I'll say things like swelling, there's things of pain, and you get a call from at midnight. They're having swelling and pain. They talk about that. Or you have the 25-minute conversation about the broken Tylenol. You can take the oxycodone and elevate and rest and ice. And it was like we talked about all of that, but then there's patients that you kind of get sick of that and you just overkill all the information. You're like, this might not work. It's kind of like the majority of the conversation's all doom and gloom, and they kind of get to the end and you're like, well, why are we even doing this? Because there's a chance that, and those patients come back and they're like, either, oh yeah, it worked really well, or they're like, yeah, it didn't work as well, but you said that, and I knew it going forward. And so those patients, I feel like, are easier to move through the treatment process with than the ones who are like, it hurt, that's crazy. Like, I got the injection and it hurt after. Like, yeah, that was like a real chance.
Yeah. Robert, did you have something?
I think that sometimes the expectations were also colored by their friends and family and everybody else.
Mm-hmm.
So I had a patient, I think he's like 75, he had a frown on, he had a little bit of discectomy. He's like, yeah, I walked out and there's no pain, it's great, I'm back to doing things. I'm like, whoa. let's slow down just a half second. You had back surgery.
Yeah.
I understand, like, oh, I'm trying to walk 5 miles today. I'm like, that's what everybody wants to hear was I had back surgery and I walked out of there perfect, right? So
Yes.
it's the outlier on the other side that also skews our expectations sometimes with other patients.
I agree with that. Yeah. So these are, you guys hit on a lot of them. Set realistic expectations. I like to make sure that we're reviewing the common symptoms of things that can occur so that they're not so shocked when they do occur. Personalized care plans. I think this patient, when he came back again, I had him bring a translator. And once he understood, he went and did the physical therapy and he actually got better. So it was just that he didn't understand the reasoning, and so he wasn't going to do the thing until he truly felt like it would be a benefit to him. Predict outcomes accurately. So I think also being able to diagnose someone so that you can accurately treat them is also a way to meet their expectations. Active listening, and then use empathy and compassion. What are the biggest barriers we see in helping patients understand their procedures? Yeah?
Selective hearing.
Yeah, I would agree with that. I think sometimes they hear what they want to hear, like, kind of, not that this wasn't a thing, but like with him, he was thinking all focus was here, and so he didn't want to do anything else anywhere to just even see, because we weren't sure where the pain generator was coming from, and so having them be able to be open to the communication we're giving. Yeah?
I think they're scared, they're fearful of the future, maybe they're losing their job, maybe they're going to be out of the job. There's just so many things that they can't process right now.
Mm-hmm.
Maybe they're only taking in 20% of what you're saying.
Yeah, agree. Yeah, Morgan.
I also feel like matching up timelines of a lot of patients be like, I've got a trip in October. Like, we've got to be able to do X, Y, and Z for that. And instead of say like, the body doesn't listen to that timeline, right? And so understanding that you may have to make some more adjustments, but the physical therapy alone can totally manage that thing.
Great.
So, I don't work there enough.
David?
I think it's a bit of wading through the mud and mire of all the information. They will catastrophize. They can have the information overload, and so kind of like we talked about it before, is like the barrier is there is a lot of information out there. There's a lot of the patients who have the high expectations. I'm going to walk after day 2, and then the ones who can't move or won't move. Because if they stand on their plantar fascia, it's going to tear it. Oh no! So then it's trying to help find that information overload. What's going to be the best thing for that?
I love that. Yeah.
I think a big part is building trust with your patients that I really trust you, and whatever standard protocol, then stick with it, and have proven results and present that to your patients around the globe.
Yeah, I love that. I think trust is a big deal when it comes to our patients, and so if they don't trust us, they're not going to benefit from anything we say.
I think their previous experiences have something to do with it too. If they've had experiences with that same thing, or maybe a family member, right? So they come with these preconceived ideas or these thought biases where you're going to spend 5, 10, 15 minutes explaining to them what's going to happen, and then none of it goes through because they already have this thought process of what's actually going on, what's going to happen because of what they've experienced already or someone they know.
Love that. All right. Great job, guys. I think some of the barriers we have are obviously language and cultural. Emotional distress and anxiety can play a key role in anyone's ability to actually take in and absorb what's being given to them, because I know, like, when you're hurt or pain, like, things are your focus is elsewhere. So Cognitive or sensory impairments, information overload. I think we oftentimes, give so much at once. So maybe breaking it down into different visits where we give them a little bit each time so they can process it and then make sure they can use it accurately. Inadequate teaching methods. Are you guys using any specific methods in your offices, such as, what's everyone using as far as ways to teach their patients?
I've done, in the industry, I've done spinal cord stimulation, so very heavy, like patient instruction and things like that. And I've noticed when I instruct or tell a patient how this new therapy, this new device to them is going to work, if they go home with a little handout versus just a verbal instruction, they're so much better off. So many less questions when I'm presenting them with something they can kind of take home or study or kind of go through it. And like that little method of sharing that has saved me probably hours of explaining things over the phone.
Awesome. Anyone else? Yeah.
We always like to text our patients. I know not everybody likes to get out their phone number. We actually give our phone numbers to our patients and say, here's a summary of what we discussed. Here's your homework. Here's the things that you need to do. If you have any problems, give us a call or text us. And so most patients don't abuse that, but it's nice when they do have a question, they can call us and they reach out and we can get it answered in real time. And
yeah, that's
so
awesome.
Keep on track.
I love that. I know myself, I like to have it in physical copy so I can read through it. So yeah, I think just having different ways where we can offer our patients videos or a pamphlet, a written thing, the ability to follow up with us, those are all really beneficial in helping that they're not having these barriers to their communication so that they can better understand what treatments we're giving them. And then are there ways that we personalize this education to meet each patient's needs? I mean, we kind of have talked about it, but anything else you guys want to? Yeah.
I think also, the conversations that are outside of what you're teaching them, they have to weigh insurance, they have to weigh, appointments. Making that as easy as possible. I like to do that, to be able to say, okay, what are your time constraints? What are your limits? How is your insurance? And all those conversations, I think it helps them focus a little bit better on the most important parts of the conversation.
I love that. Yeah. I think for us currently, expectation-wise, something that we've been trying to adjust and do is because we're out a little bit with scheduling. We're busy practice, obviously. But maybe adjusting what we're doing so that instead of scheduling a patient before we get an authorization so that we're not letting them down, should they get denied a surgery, we're now authorizing before we schedule it. Because we've seen that that's been a barrier where, if you're not meeting that expectation, that can cause real issues for them, distress. They've changed their plans, they've scheduled things, they've got off work. So that's something we've kind of done that's been really beneficial. Okay. These are some of the other ones in the research. Health literacy, so just use simple language, avoid medical jargon. Medical or language differences, so make sure you have the interpreter if they're going to be in your office. Using the teach back method to confirm understanding, so having them kind of repeat back to us what we taught them to make sure that we're all on the same page, because as that game of telephone that Katie did, you can see how it gets lost in translation. Also including family members or caregivers. I think we see patients a lot that are elderly, maybe they're cognitively a little altered, so making sure that there's someone there that actually can proceed with what we tell them. Offer follow-up opportunities and ask for feedback. And then let's see, how do I click on the video? Is it easier to click from here? So this is just a funny video on kind of
that you have achalasia, which explains your dysphagia and your profound cachexia. What does that mean? Do I have cancer? Cancer? No. Are you not listening to me? I've just never heard of chalasia, so when you tell me that I have one, I don't know. No, you have achalasia. I don't even know what chalasia means. Why is this so hard? And why am I losing weight and having trouble swallowing? Do I have to say it? Yeah, what? Can I have a word? I'll be right back. What's up? So when you talk with patients, it's important to avoid medical jargon. Jargon? Like achalasia, dysphagia, cachexia. That's not jargon, that's just the facts. Well, people without medical training might not know those terms, so you need to meet them at their level. So like, dumb it down? Well, that's not the nicest way to put it. Just use words that anyone would understand, and then you think it's foolproof. Sorry about that, sir. Doc, just tell me what's wrong with me. Your yummy, yummy munch won't slide down into your tum-tum because you've got bad throat squeeze. That's why you go choke, and barf me a lot, and why you're smaller now and feel achy. I'm sorry, what? Okay, there's no way that wasn't dumped down. How can you come here again?
I think that's funny because we oftentimes do get ahead of ourselves and we start talking. I've actually thought this has been really interesting because we now use a little bit of the AI translation stuff. So listening to the words that it'll put in my dictation, I'm like, wow, maybe, you realize what you do and don't say. Or I'm having the opposite problem where it's dumbing down my note a little bit, if you'd call it that, to where I want the medical terms, but it's using the terms I'm using with my patients, which is a good thing, I guess, because hopefully they're better understanding it. Let's see. And then this is something I'm truly interested in because you guys see all of our patients, before and after surgery. What common gaps do you guys see in post-procedure instructions or patients' understandings? What are they coming back saying that like, hey, maybe this isn't quite right, and what can we do better? Yeah.
I don't know if this is they didn't do right or whatever, but the thing I've seen most often is people don't understand how much it's going to hurt.
Yeah.
Like the pain levels. They think it's going to be this freeze, and so, they're having pain, and I'm like, that's normal. Like, that's super normal. Take your pain meds.
Yeah.
So.
Yeah.
I think one of the hard parts that I've seen is that there's the hospital piece between you guys and when we see them afterwards. And they have a lot of people talking to them, like when they go into the hospital and they're getting instruction and they have new nurses and and I've been there, I totally understand. But that piece is kind of one of those hard to control pieces of what education our patients are actually getting. The last thing they get is a running dialogue and a big packet from the hospital, and then they go home and they're like, oh crap, what'd they say? And they're excited about going home, but they've missed all that, and they may not remember what you've told them a month before the surgery. So I think that area right there, I have ideas, but I'm not 100% sure how to fix that. But that's a hard kind of gap piece, I think, for all of us, is that we're not able to control or to manage that hospital piece very well.
Yeah, I love that. I actually went up, I think a year ago, down to Utah Valley and met with all the floor nurses for the 7th floor for where we send all of our patients post-operatively, and kind of just went through our instructions, hoping that, if they were on board with what we were saying or knew what we were saying, we could kind of connect those dots and our patients wouldn't go home hearing one thing from this person and another tells them this. So, yeah.
When I think about patients in like the outpatient sports setting, post-surgical, I feel like they have a really good understanding of what immediate post-op might look like and then what long-term return to sport might look like, but they miss the in-between. And thinking of like an ACL patient, they come in and they're like, oh, I'm not going to be doing anything for 9 months, and like their whole life is ruined. It's like, no, we're going to be running in a few months. There's more to it than just, here's when you return, here's what laying in bed for 2 weeks look like.
I love them. Yeah, we're grateful for you guys who are able to kind of help them through that intermediate process. I think we're almost out of time. So what the research shows regarding pre-procedural education. So benefits are reduced anxiety. Studies show a 20 to 30% reduction in patient anxiety with structured education before procedures. The systemic review from John Hopkins found that preoperative education reduced anxiety scores by 25% on average. That's huge. I feel like if we can take it down even a tiny bit, that's a big impact. Improve patient satisfaction. Patients who receive thorough pre-op education report 15 to 25% higher satisfaction scores. And then improved compliance and recovery. So patients are 1.5 to 2% more likely to follow pre-procedure and post-op instructions. So fasting before a surgery, what mobility they can have, those kinds of things. If we're educating them, obviously they're going to follow those a lot better. And then post-operative recovery times are reduced by 10 to 20% in some procedures due to better preparation and engagement. It also has an economic impact. Hospitals that implement formal education programs prior to elective surgeries reported a 10 to 15% cost reduction per patient due to shorter stays, fewer complications, and fewer readmissions. Case-specific research that I found was surgical procedures. A study in the Journal of Bone and Joint Surgery found that pre-op education reduced length of hospital stay by 1.5 days for total knee replacements. And then in cardiac surgery, patients who received structured education were 40% less likely to be readmitted. So I think that's great statistics. I think if we can all do our part to set our patients' goals in line with their goals and expectations together and better educate them so that they can achieve those, we're going to really help our patients. And then patients don't just need treatment, they need preparation. When we set expectations, we empower outcomes. So I'm hopeful that we can all do that in our practice and work together as a community, which I know we do really well, and I'm grateful for that. So any questions? Okay, thanks for coming, you guys.